Ladies and gentlemen, a wonderful good morning, good afternoon, good evening around the globe. Welcome to our LEICA 2021 Online Neurosurgical Visualization Summit. My name is Jennifer Boone, and I have the great pleasure to be your host for this week. And I'm very happy that you are joining us today for our clinical symposium on the neurosurgical treatment of spinal arteriovenous fistulas with Dr. Charlotte Flue. Before we go ahead and start, I would like to give you just a couple of tips to make it the best possible experience for you. First up, please submit your questions during the entire presentation, and we will then get back to the questions at the end of the session. So you are welcome as soon as a question pops into your screen, and then we will answer the questions after the session. On the left side of your screen, you can see that there are resources available that are linked to the topic of this symposium. We welcome you to bookmark them, and then you can browse through the resources after the session. Also, from a technical standpoint, we recommend that you firstly disconnect any VPN you might be using, that you close all unnecessary tabs and applications that you don't need for this presentation, because our speakers will be showing high quality images and videos, and of course we want you to see them in the best possible quality, so don't waste any bandwidth on applications that you don't need to have open right now. And then last point, if you have any issues, then press the F5 button to refresh your page, and then hopefully any issues like freezing, for example, will be solved. So another important point is that I would like to mention that off-label use of products may be discussed. Please check regulatory affairs for cleared indication for use in your region. And please also note that the statements of the healthcare professionals as part of this symposium reflect only their opinion and personal experience. They do not necessarily reflect the opinion of any institution with whom they are affiliated. So now we have got the official part out of the way. I am very happy to hand over to Dr. Charlotte Flue. She's a neurosurgeon at the University Hospital of Schleswig-Holstein-Kiel in Germany. She's also the Neurosurgical Research Laboratory project leader and a reviewer for Molecular Medicine Reports and the International Journal of Oncology. In addition, Dr. Flue is involved in several multi-center studies. Dr. Flue, please go ahead.
Thanks, Jennifer, for the introduction. Hello, everybody. My name is Charlotte Flue, and I will give a talk about the treatment of spinal arteriovenous fistulas from a neurosurgeon's perspective. First of all, I will give a short overview. So I will give some information about the anatomy of the spinal blood supply, then about the definition and grading of those fistulas, about the pathomechanism, the symptoms, the epidemiology, diagnostics. Then I will show you 3 cases from our center and others, and will then give a short overview about the pitfalls for the neurosurgeon and about the advantages of the usage of ICG in the operative treatment of spinal AV fistulas. In the end, I will talk a bit about the outcome of those for those patients. So talking about the arterial vascular anatomy of the spine and the spinal cord, one has to keep in mind that there are 2 posterior and 1 anterior spinal arteries, which usually are supplied by segmental arteries. The feeders for those arteries usually come from different vessels. So on the cervical levels, you have the ascending cervical arteries. On the lumbar and thoracical level, we have the intercostal and lumbar arteries, and for the sacral levels, we have the iliolumbar arteries. And they actually supply the vertebral bodies, the paraspinal muscles, the dura, the nerve roots, and of course the spinal cord. what is very important is that in the adult patients, not all lumbar or intercostal arteries have a radicular medullary feeder, and actually their localization for every patient is not predictable. So we have a huge inter-individual variety. And what one has to keep in mind is that there is one very big or very important radicular medullary artery, which is called the Artery of Adamkovic. I will tell you a bit about that later. Now I will come to the blood supply of the dural sleeve, which is very important to keep in mind when you're talking about the treatment and the diagnosis of spinal AV fistula. So usually we have that, especially in the thoracic level, that intercostal artery, which has a ventral and a dorsal ramus, and that dorsal ramus then goes to the, I hope that everybody can hear me. The dorsal ramus then splits up into a so-called radicular medullary branch and a radiculo-dural branch. The radiculo-medullary branch follows the anterior and posterior nerve of the root, so it kind of goes into the dura and then goes to the anterior and posterior surface of the cord, actually, where it forms the anterior and posterior spinal arteries. So knowing that, we are coming back to the Artery of Adamkovic. So as I just said, it's the best known anterior radicular medullary artery, and it was described by the Polish neuropathologist Albert Adamkovic, and it actually supplies 2/3 of the lower spinal cord. So it is very important in a clinical way. It usually originates from the 9th to the 12th intercostal artery. Usually it comes from the left. You have a very individual cause, and it's not the same in every patient. What is important to know is that if you would occlude the Artery of Adamkovic, this usually results in a huge spinal infarction, or so-called anterior spinal artery syndrome, resulting in a loss of function of the anterior 2/3 of the spinal cord, which usually leads to complete motor paralysis below the level of the lesion, the loss of the pain and the temperature sensation, but a retained proprioception and vibratory sensation due to the intact dorsal columns. So this is a very, very severe neurological condition. Coming to the next point, which is the vascular anatomy of the spine and the spinal cord. So usually the veins run along with the artery. So we have that venous drainage of the cord, which is organized via a radially symmetric system of intrinsic spinal cord veins and small superficial PL veins, and they actually open into a superficial longitudinal median anastomosing system of spinal cord veins, and these then actually follow more or less the arteries, so the anterior and posterior spinal arteries. But what is very important to know, the veins of the spine and the cord, as in many other locations, have many anastomoses. So this basically creates a network of more than one anterior and posterior spinal vein. What also is very important is that in those networks, we don't have any valves. So the epidural and the intradural venous plexus is a bit comparable to the veins of the brain and to the dural sinuses, where we also don't have any valves. Usually then the veins travel with a root as a vehicle to reach the epidural plexus and the extraspinal veins, where you actually have a reflux impending mechanism with a dura mater. This I wanted to say about the veins. Now we are coming to the classification system of arteriovenous malformations of the spine. And here we have a classification which was described or first introduced by Spätzle and Anson in 1992. And they actually divided all the pathologies into 4 different types. I want to start with the first type, which is, I think, the most important and the most common one. So the type 1 dural or spinal vascular malformations include the so-called dural AV fistulas, and I will talk about that entity for the rest of the talk. So there are 3 other types which I just want to briefly introduce. So type 2 is the so-called Glomus Avm, which has a nidus inside the spinal cord, which has intradural, which has an intradural localization, and usually then is localized intra or extramedullary. It is the second. The incidence is a bit lower than the one of the type 1 fistulas, but it is the second highest, but still it is very rare, actually. Then we have that type 3, which is described as a juvenile AVM. The nidus is not as dense as in the type 2. It's usually also intradural localized, but has intra or extramedullary parts. And then we have that type 4, which is also described as a pia pile AVF, and it's actually a connection between the spinal artery and the spinal vein, is localized intradurally but extramedullary. So what I will go into a bit deeper now is that type 1, Spätzler and Anson. And as I said, these are basically dural AVFs, and they can be divided into 3 subgroups. And the first subgroup is the so-called Extradural Av Fistula, which is a direct connection between a distal branch of a radicular artery, so that usually the radiculo-medullary artery, and the epidural venous plexus, or the corona venous plexus, which is intradurally, which is extradurally. They are very rare, actually, and usually these veins, which this pathology drains into, are known as the basivertebral venous plexus, which subsequently drains into the anterior internal vertebral venous plexus. And this one is located in the epidural space in the spinal canal. So these draining veins do not only drain this shunt, but also usually the bone. And usually these patients do not become symptomatic due to venous congestion of the cord, but become symptomatic due to the compression of the spinal cord or nerve roots by the enlarged epidural venous pouches. So usually, and here I have a picture of it, the patients, so you have a few cases described in the literature where you have associated perimedullary reflux, this causing congestive myelopathy, but usually in those patients you have a compression of the cord or of the roots due to the space occupying character of those lesions. And here you see with a black arrow the typical nidus of those lesions, which is extradurally. What is very important to note here is that due to the fact that the epidural venous plexus also drains the bone, you sometimes have an involvement of bony structures. These lesions are, in the majority, treated interventionally. So at least in Germany, where we have that division between neuroradiology and neurosurgery, it's not usually the neurosurgeon is not involved in the direct treatment. Coming to the next group of dural AVFs, which is also described as the dorsal intradural AVFs. This formerly in that Spätzler and Anson classification was referred to as type 1. And here we have the most common types of dural AV fistulas. They are also described as the so-called lateral epidural DAVFs. And here we have a connection between the radicular artery and the corona venous plexus. So the localization of the nidus usually comes from the radicular artery, which then is connected directly to that corona venous plexus, which is intradurally. And due to an outflow of obstruction of the adjacent venous outlet, either due to thrombosis or fibrosis related to aging, this immediate drainage of the artery into the perimedullary veins is introduced. This type makes up to about 80% of all dural AVFs. So it is the most common case. And actually, due to the fact that the proposed reason for this fistulas is a thrombosis or fibrosis related to aging, the patient group is usually a bit older. I will talk about that later. So we don't have any kids or any young adults in this patient cohort usually. And actually, the arterial vessel which feeds those fistulas usually does not have a high flow. Due to it then leads to venous congestion in that corona venous plexus. This leads to edema, to myelopathy, and actually to venous hypertension. And this lesion, therefore, is a typical low flow vascular malformation, which I will talk about a bit in the following. And the treatment also will be discussed. So here we have a picture of it, of that typical dorsal intradural AVF with a direct connection between the radicular-medullary branch of the radicular artery and the intradural corona venous plexus, leading to, as I said, venous congestion, edema, and myelopathy. Now I'm coming to the last type of those dural AVFs, and they are the so-called ventral intradural AVFs. And here we also have a direct connection, but this one is between the anterior spinal artery, so that's why they are called ventral intradural AVFs, and the corona venous plexus. So here we usually have a singular feeder, and they are divided into type A, B, and C regarding to the volume of the shunt. A is a small shunt resulting in a small flow, and B and C have increasing shunt components and a higher flow. These lesions are also extremely rare, and they actually are localized like this. So you have that, as I said, that connection between the anterior spinal artery and the corona venous plexus, which also then is enlarged. And in these cases, usually due to that direct connection to the anterior spinal artery, which is a bit bigger vessel than the radiculo-medullary branch of the radicular artery, you usually have a vascular steal effect and also a mass effect, which is increasing from level A to type A to level to type C. Then the obstruction of the venous outflow usually leads to an arterialization of the corona plexus. This then leads to hypertension, and this also results in myelopathy. So usually in those patients, you have a combination of vascular steal and myelopathy. The treatment option in those patients usually is endovascularly. So coming back to the pathomechanism, which is very important, I think, to become clear. So we always have to divide into low flow and high flow vascular malformations. I think that's a general principle for every vascular neurosurgeon to think about. And actually in the low flow malformations, you usually have that high component of venous hypertension, which then results in the reduction of the arteriovenous gradient and perfusion. And it also leads to a intramedullary or a corona vasodilation. These two points then lead to a progressive hypoxia of the spinal cord, and that dilation of the vessels lead to a loss of autoregulation. And those two components then result in slowly evolving symptoms of myelopathy. So it has to become clear that low flow lesions usually do not present with acute symptoms, but present with slowly evolving symptoms of myelopathy. In contrast to that, high flow lesions, as for example, the ventral intradural AVFs, or also the extradural AVFs, usually result in a vascular steal phenomenon. This results in a spinal cord ischemia. The high flow malformations tend to have more feeders than the low flow malformations, and due to the high flow component, they often develop arterial and venous aneurysms. And these can rupture, of course, can lead to hemorrhage. Spinal cord ischemia and hemorrhage both usually lead to acute sensomotor deficit. So that is the pathomechanistic difference between those two lesions. now I will come to the clinical symptoms of low-flow dural AVF, so that typical, most common type of dorsal intradural AVFs. As I said, these are low-flow lesions, so you usually don't see any acute bleeding. This is a bit different in the cervical low-flow dural AVFs, but the cervical localization is quite rare. And actually, the patients usually present with prolonged symptoms of venous congestions. And these symptoms are typically nonspecific. The patients usually report thoracolumbar pain. They report slowly progressing sensomotor deficits, leading to paraplegia in the end. They often also have bowel and bladder dysfunction, and they have gait disturbances. And many patients report that post-urally, so activity, physical activity leads to aggravation of symptoms. What also is very important to keep in mind is that if the patients increase the intra-abdominal pressure, which leads to reduced venous outflow of the spine and the cord, like in a Valsalva maneuver, straining, or pregnancy in women, this also can lead to an aggravation of symptoms. And actually, in some very severe cases, you don't just have that lower motor neuron involvement, but also an upper motor neuron involvement, which leads to clonus, a positive Babinski sign, and also, as I said, this symptoms of myelopathy. And this then, usually that maximum variant is then called the Foie syndrome. I'm not perfect at pronouncing that the name, but it basically is a subacute necrotizing myelitis due to a maximal form of venous congestion of the spinal cord. The patients usually present with rapidly progressing symptoms of myelopathy, and what is very important, they are very responsive to treatment. So Théophile Allergy was a French psychiatrist. He was born in 1890, and Charles Foie was a French neurologist, also born in 1882, and they both described this syndrome. So what are the differential diagnoses? So as I said, the symptoms of those low-flow lesions usually are rather unspecific. So it is very typical that the patients don't present to a neurosurgeon or a neuroradiologist in the first place. Many are seen by orthopedic surgeons, by urologists, by psychologists, by neurologists. And what you, of course, have to differentiate, also because many of the differential diagnoses are much more common than dural AVFs, are spinal stenosis, especially the cervical stenosis, degenerative disc diseases, neurogenic claudication, polyneuropathy, and spinal tumors, and especially in the anterior dural AVFs, which are, as I said, localized in the anterior spinal column and include the anterior spinal artery. You have to differentiate them from inflammatory lesions and from spinal cord ischemia. So these are the main differential diagnoses. Coming to the epidemiology. So as I said, all these lesions are very rare. The dorsal intradural AVFs make up for about 80% of all lesions, and they have an incidence of 5 to 10 cases per 1 million inhabitants per year. So they are very rare, and they are often overseen. About 80% of the patients are male. The mean age is 55 to 60 years. The most prevalent localization are the thoracic levels, a bit more common than the lumbar levels, which are themselves a bit more common than cervical levels. So what you can say is that about 80% of the fistulas are localized between T6 and L2. Cervical level is very rare, only in 2% of the cases, and sacral level is also very rare. About 2% of the patients have additional spinal malformations, so it is still, although it's rare, important to look at that. And as a consequence to the very low numbers, we don't have any prospective or randomized multicenter studies. So usually the patients are treated on a center-based regimen. What do we have to, what kind of examinations do we have to perform on the patients before they are treated? Of course, you have to evaluate the neuro status, you have to evaluate the urodynamic status, and all the patients have to receive a spinal MRI and especially a digital subtraction angiography of the spine. So what do we usually see in a spinal MRI? So I here have two typical pictures. So what is very specific for a lesion, but not, but it of course can be then other lesions as well, is a type T2 hyper insensitivity in the spinal cord due to the vasogenic edema. Many patients also show a contrast enhancement on the level of the myelopathy. You usually, and this is what you see on the right picture, you usually see those elongated intradural vessels, which can be seen or described quite well in a venous MRA of the spinal cord. This actually is not that easy to be performed, and as far as I can experience or report, you really need an experienced neuroradiologist to perform a really good spinal MR angiography. What also is very important to know is that the extension and the localization of the edema does not always correspond with the localization of the nidus. So you can't really tell where exactly the fistula is from just looking at the T2 sequence. The venous MRA gives you a bit more information about where to look, and it can be quite specific. What is important to know is, I think, that the gold standard of diagnosis, which also gives you the kind of safe knowledge about the localization of the fistula, is the spinal digital subtraction angiography. What is very important here is that usually the neuroradiologists have to look at every single radicular artery. As I said, they vary a lot between different individuals. And what also, of course, is important to know, and you should always ask that to your radiologist before he performs the angiography, is where the Artery of Adamkovic is originating from. Because if you treat the fistula and you have to occlude a radicular medullary branch, you of course need to know whether it's the Adamkovic artery. You shouldn't occlude that one, actually. So what also is very important is that in that angiographies, you usually see that the veins fill very early, and you also see that the venous return is very slow. Some of the lesions have that low flow component, or many of them have it actually, and due to that low flow, it's sometimes, or the frame rate of the angiography has to be quite low as well, about 1 image per second. Or at least something like 4 images per second, because it's the filling of the fistula can be seen better then. Coming from this, we'll talk a bit about the therapy of spinal AV fistulas. So as we don't have any multicenter studies, the treatment plan usually is an individual one. What one has to know is that the endovascular obliteration rate is about 50%. So you find studies where it's about where it's described to be 25%. You find studies where it's 75%. That is not very high. So it has to be so usually, or many patients additionally have to be treated with an operation, but the morbidity also is very low. So in many cases, it makes sense to at least try to treat the patients interventionally. If this does not work, surgical treatment is the best option. And there are many papers out there showing that you should treat those patients primarily in an operative way, but the and this is actually due to the fact that the obliteration rate of dural AV fistulas is very high if you operate on them. It's described to be like 98 to 100%. The morbidity due to the operative nature of the approach is a bit higher than in the endovascular treatment and lies at about 2%. So usually, and this is what we do in Kiel as well, you have a center-specific strategy, which in our case includes one trial of embolization, and if this is not successful, an early surgical obliteration. What is very important, of course, is that the glue that you apply and the surgical occlusion that you apply is at is before the nidus, so you can really occlude the nidus. And what is also very important is that you don't wait too long to treat the fistula, because and this is what we experience in our clinical practice, but what also can be experienced in the big or the bigger, they are not really big, but the studies that we have is the patients slowly develop symptoms, and the longer you wait, the severer the symptoms are, and the less they are responsive to treatment, especially the urinary incontinence. So if you diagnose a fistula in a patient, you definitely should go for a treatment in the next days or weeks, but you shouldn't wait for months usually when you diagnose it. So here I have a case of an interventionally treated patient. So it's a guy from our who presented to our department with a progressive paresthesia in both legs. He presented with the typical signs in spinal MRI, and he basically can see the probing of the segmental artery of L2 on the left, which is leading into a typical dorsal intradural AV fistula. And here you, for example, can see that typical run of that segmental vessel, which then was occluded by using onyx. So what is very important is that you have to occlude the proximal segment of the draining vein to prevent a subsequent intradural collateral filling of the fistula, and therefore proximal occlusions, so for example an occlusion just of the radicular branch with coils or gel foam, are usually not sufficient. Embolization with particles also is, as far as we know, very prone to recanalization, and we therefore use onyx, which is ethylene vinyl alcohol copolymer, and this, as far as I can judge from our experience, works quite well. So here we have the typical interventional case. Coming to the next case, which is a 65-year-old male who also presented to our department with dysesthesia in both legs that had been going on for 2 years. He also had been to many different other specialists who did not diagnose the AV fistula in the first place. He reported that he had difficulties, especially when walking longer distances. There was no other neurologic deficits, and very important, there was no urinary incontinence. So this patient received a spinal MRI, and I want to show the T2 weighted image. I hope that everybody can see it. You here can see the typical, and I just started again. You can see here the typical T2 hyperintensivity in the conus and the spinal cord itself. Next sequence is the venous MRA. It is scanned in a corona fashion, and here you can see that dorsally of the myelin at this place, you can see those elongated veins, which are on the dorsal side of the spinal cord. So what we performed next was a spinal angiography, and here in the first image, you can see the diagnostic spinal angiography. where the catheter is in the segmental vessel, and in the late phases, you can see, I do it once again, you can see the very early filling of the veins and that typical hairpin-like shape of the dorsal branch of the radicular and medullary artery. We then performed a trial, we tried to occlude that vessel interventionally. This actually did not work properly, and here you can see the post-interventional spinal angiography. You probably wonder, and I go back slide, you probably wonder what this actually is. So there is a little coil. It's not in the vessel because the vessel was much too small to go there with a catheter and occlude the fistula. But the neuroradiologists put a little coil in a muscle branch of that segmental artery to make it easier to identify the level. And that is something that I can definitely recommend to anybody dealing with that dural AV fistulas, because usually it makes it much easier to identify the level which has to be operated. Of course, you usually use X-ray for localization of the right level intraoperatively, but this gives you a bit more security. So in this patient, we decided to operate and consented him, brought him to the OR. This is how we usually position the patients. So they are positioned in a prone position. We then usually use a Wilson frame to position the opening of the dura at the highest point of the operative field to decrease or reduce the loss of CSF. And then the patients usually get a hemilaminectomy or a partial laminectomy. This part of the lamina then is removed. And what you want to see actually is the nerve root exiting the spinal canal, and that connection point definitely has to be seen. So in most cases, you have to remove the 50% of the lamina, and usually that branch or the root exits directly beneath the pedicle. So here you can see the intraoperative picture of that patient. So as I said, the fistula was, I think I didn't say it, but the fistula was at the level of L3 on the right. So here you can see the dura exposed on the right side. Right is lateral, left is medial. Here's caudal, and the head is on the upper side of the picture. And here I then have an intraoperative video. So what I will show in a second is what I see from the operative field. So you can basically see the lateral dura on the down part of the picture. Right is up, left is where the feet are, and the medial side is up as well. So here you can then see the video. So we opened the dura. You can basically see where the nerve root is. I have a little gauge swab on the intradural part of the nerve root, and here you can see that big segmental vessel which enters the spine or the dura with the nerve root. And this is the feeding radiculo-medullary branch of the fistula, and it therefore has to be occluded. I here use a bipolar forceps, which is put on a very low current, actually. You occlude it, and then you cut it, which is a bit later now coming. So of course, what I didn't show here now is the part of the operation where you can see those elongated veins on the dorsal surface of the cord. we usually do that under constant irrigation to not hurt the nerve root. And what also is very important in this case is that the nidus itself is above the level of the entry of that vessel. So usually, at least not in all operations, it's not possible to identify or to see the nidus itself because it's not always on the same level. You still, of course, have to occlude the vessel at the entry point. And you also, of course, have to check that that the fistula is occluded, but not in all cases it's possible to see the nidus itself. So now the vessel is cut, and usually we then perform an intraoperative Icg angiography. I do not have this on video actually, but and this is very important as well. You have to perform a post-operative angiography. And this is what I show here. So the patient received a dural closure. The wound was closed. I usually do not put a drain in when the dura was open. And the patient then receives, like on the third or fourth post-operative day, or even a bit earlier, the post-operative spinal angiography. There, of course, you don't have to check every level, but you, of course, have to check the level where the fistula was. And here now you can basically see the catheter in the segmental artery, but the fistula is occluded. You don't anymore see the that early filling of the veins and that happen-like shape of the radicular medullary branch. So coming to the second case, also treated surgically. So this also was a patient with a typical symptoms with paresthesia of both legs, and in the preoperative MRI, you could identify a intradural AVF with a single feeding artery on the right, coming from the segmental vessel at the level of T7. The patient then also was operated, and here you can see the intraoperative picture. So you can see those elongated and hyperplastic spinal veins on the right. You can see the entry zone of the radiculomedullary branch. You also can see the intraoperative Icg angiography, where you can identify the nidus very well, and this then was occluded. So coming to one other very important issue, which is the usage of Icg in the OR. So Icg has frequently been used in cranial vascular malformations and aneurysms, but the first usage in spinal vascular malformations was described in 2009, so that's not long ago, actually. The Icg angiography has to be performed before and after the occlusion of the fistula, of course. It actually may help to localize the draining vein intradurally. It also may help to verify fistular occlusion, but one definitely has to say, I never would rely on that or just on the Icg angiography, but you, of course, also have to look at the vessel color and the blood flow, for example, in microvascular Doppler examinations. So, but still, the Icg angiography can definitely help you to identify the occlusion. What also is very important is that not in all cases you can identify the nidus in the operative field, as it might be above the level of the supplying vessel. In my opinion, the Icg angiography does not replace a post-operative digital subtraction angiography, and as I can judge, most authors also see it like that. It is not mandatory, but it is very, very helpful. So usually, and this is what you can take from that publication of Takai et al., the intraoperative Icg angiography, in some cases, about a third of the cases, 36% is what they found out, changes the surgical procedure. So you definitely know better if you occluded the fistula, and you can localize it much better, and you can achieve a much better level of security concerning that intraoperatively. So I would definitely recommend to do it, but it's not the only way to control the effect of your operation. Coming to the pitfalls of the operative procedure. So what is very important, in my opinion, is that you identify the right level of the supplying radicular artery. As I said, you don't always see the nidus of the AVF, so you have to be 100% sure that you are at the right level. This actually means that you need a very, very close cooperation with your neuroradiologist, because he needs to tell you first where the entry is and where the supplying vessel is, and he needs to tell you what level the Artery of Adamkovic is at, so you can avoid complications. In patients where you see that the supplying vessel has the same level as the Artery of Adamkovic, usually an interventional procedure makes more sense in the first place. And of course, you can operate on those patients as well, but it has to be in those patients. You of course have to be directly at the nidus to occlude the fistula. Coming to the slide before the last slide, what is the outcome of the surgical treatment? So usually in the majority of the patients, we see an improvement of the symptoms in above 90%. Especially the gait improves in about 76%. Motor symptoms improve in about 2/3 of the patients. What is very important to know, and you need to tell the patients that in advance of the procedure, is that sensor deficits only improve about in 1/3 of the patients. Concerning impotence and sphincter disturbances, it is clear that these symptoms do not really react to the operation, so they are mostly irreversible. So it is very important to treat the patients before they develop such symptoms. And what also is very clear is that you have a very tight association between the pre and the post-operative status. So the patients who have very mild symptoms usually recover very well, and the ones who have severe symptoms need longer. An early treatment is very important to prevent severe myelopathy. And what also is very important, the patients need a long-term follow-up. So usually we perform a directly post-operative spinal angiography, but that should be, but the patients need to stay in follow-up for at least 3 to 5 years. So how we do it is that they usually receive a follow-up MRI of the spinal cord in 3 months, in 6 months, and in a year. And if you see, or there you usually see a decrease of the T2 hyperintensivity, you should see a decrease of those venous elongations dorsal to the cord. If you don't see that decrease in those two entities, the patient should receive another spinal angiography to control if there might be a reopening of the fistula or another level of supply. So summarizing what I just said, we now know that dural AVFs are very rare, that they are graded by Spätzle and Anson and the modification. Most patients present with slowly progressing symptoms of myelopathy. Diagnosis is made via MRI and spinal angiography. The treatment is a combination of intervention and surgery, and usually this treatment is very effective, especially if it's performed early, and also feasible and necessary. With this, I want to conclude. I'm very open for questions, and I thank you very much for listening.
Thank you so much, Dr. Charlotte Flue, for giving us these great insights into your work and into your experience. Dear audience, we hope that you will take away some great learnings. Before we head to our questions, we would like to highlight the LEICA technologies that support spinal arteriovenous fistulas. Those are the Arvio Digital Augmented Reality Microscope, the M530OHX Surgical Microscope, and the FL800 Fluorescence Module. If you are interested in learning more about these technologies, please do not hesitate to reach out for your private session. You can see on the slide there are numerous different possibilities, so you can figure out what is the best possibility for you and then request your private session. So now, dear Dr. Flu, we would like to head into the questions. So thank you, dear audience, for submitting your questions. Let's take a look what you would like to know. So first up, thanks for the presentation. Do you remove the joint when doing the fenestration?
Usually I try to avoid that, actually. So if you do a hemilaminectomy, you definitely have to resect the medial facet of the joint. So you can't keep the joint as a whole, but that's basically what you remove. You don't need to remove anything else.
Thank you very much. Then let us see what the next question is. If the fistula hard identify, do you do intraoperative angio also?
Yes, we usually do that. Okay. I'm sorry that I didn't have the pictures of that one patient where I showed the video, but usually we do an intraoperative Icg angiography once before and after the occlusion. And then, of course, you have to look at not only at the feeding vessel, but also at the venous drainage. So at that elongated vessels, veins at the backside of the cord.
Okay, thank you so much. Then next up, our audience would like to know, ICG video angiography should be useful for the probe visualization of fistula? ?
Yeah, as I said, so in some cases where the nidus is at the same level of the feeding vessel, you can identify it, but it's not always possible, because if you have, there are cases where the nidus, for example, is like 2 levels above the radicular artery entering the spinal canal or the dura, and there, of course, it would not make sense to expose the nidus if you would have to make a 3-level hemilaminectomy for that, which would result in instability. So, of course, if you just perform a hemilaminectomy at 1 level, you usually can avoid to perform a stabilization, an internal stabilization using a fixateur. And that, of course, would not be possible if you would always expose the nidus. So usually, in many cases, you can identify the nidus, but not always.
Thank you so much. So then let's take a look at the next question. In your experience, should be option for multimodal treatment by endovascular and surgical means for dorsal intradural AVFs type B with multiple feeders and progressive venous hypertension?
So does it refer to that you should treat them in a combined fashion, or I don't, I hope I understand it right. So as I said,
so that would be the question. If by that, is that possible?
I hope that, so usually we try to present every patient who comes to our hospital, and may he present to our neurosurgical outpatient clinic or to the neuroradiologists. We usually discuss every case in our neurovascular board, where neurosurgeons, neuroradiologists, vascular surgeons, neurologists sit together, and there we then decide if we start with an interventional treatment and then do surgery, or if we then perform surgery right away. It always depends, of course, on the individual anatomy.
Okay, so I hope that answered your question. If not, then please clarify it again in the question section. if I'm operating with an opposite assistant, does my assistant have his own focus, and can he or she see and have the same image quality as me?
So usually if you have that opposing fields in the microscope, and that of course also the case if you operate on spinal processes, usually the assistant has the same operative sees the same operative field as the surgeon, but in the LEICA microscopes, usually just the surgeon can of course change the focus. So the assistant usually has the same focus as the surgeon, and is not able to vary that. Actually, I think it makes sense to have it like that, because usually the microscope just has one focus, and of course the surgeon has to have the control on that.
Okay, thank you so much. Unfortunately, we are running out of time, so that was our final question. I would like to say once again, thank you so much for taking the time to be here with us and to guide us through this fantastic presentation. And for you, dear audience, thank you so much for submitting your questions, and of course also for taking the time to be here. Our LEICA 2021 online neurosurgical visualization summit is continuing until Saturday. So you can see on the schedule, you have the possibility to register for more sessions to gain more great learning. So please feel free to join. Yes. Dear Dr. Flue, I would like to hand the word to you for some closing remarks before we end the session.
Yeah, thanks a lot. I, again, want to thank everybody who joined the session. I'm happy that I had the opportunity to give this talk here. If you have any further questions or want to discuss anything, you can always write me an email. And I'm happy to be part of the summit.
Fantastic. Thank you so much. Thank you to everyone. Goodbye and enjoy the rest of the day.
Goodbye.